Morning. First of all, I would like to thank the KSM and the Sri Lanka College of Cardiology organizing of this event and inviting me for the talk. And my topic is basically on ECG. ECG that you should not miss. The ECG is a quite extensive, vast topic, and I would like to cover as much as possible within this time frame. Basically goes with the OSCE like thing that you can answer by yourself, but we don't have the audience response system as well as the timing factor. It's limiting. So I'll go through with ECGs, starting from very simple stuff for quite a complex and rare varieties in ECG. So this is ECG of everybody knows this is asystole. So it means the both atrial and ventricular contractions are absent and the patient is in cardiac arrest, and this should be a non-chockable rhythm. But if you see a very straight line in a patient who is unconscious, but don't think about asystole, first you have to check the leads. But in asystole, you get a coarse, irregular baseline. But interestingly, the ECG mentioned down, which is also a type of an asystole, what we call the P-wave asystole, where you have the organized atrial contraction, but the patient doesn't have ventricular contraction. The important thing in the P-wave asystole, the patient has some chance of recovery if you do urgent pacing, either transvenous or a transcutaneous, because already the P-wave activities are like the atrial activities are there, but not the ventricular activities. But still, this is a non-chockable cardiac arrest if the patient is in peri-arrest rhythm. So in that case, immediate CPR should be available. And if there's a facility for urgent pacing, for example, in a CCU setting or an ETU setting, so you can try with external or a transvenous urgent pacing, where the patient's life can be easily survived. So this is ventricular fibrillation. So ventricular fibrillations you should not miss, and you should diagnose in anybody who is in peri-arrest or the cardiac arrest. So because this is a shockable rhythm, so you should shock immediately, and the patient's chance of survival are very high if you shock urgently and identify this rhythm. So everybody in the audience should know to identify ventricular fibrillation. So the other thing is the ECGs always should interpret with a clinical background. It's not just identified in the pattern in a paper. So always you have to correlate the clinical features. And the ECG is basically a pattern recognition. So you combine with the pattern plus the clinical history, your sensitivity and specificity of your diagnosis will be very high. So this is a 65-year-old patient suddenly collapsed after a chest pain. So 65 male chest pain, so unless put otherwise, okay, you will come to the diagnosis of broad complex tachycardia, most likely VT. But the first state of diagnosis is you have to make the diagnosis of broad complex tachycardia. So if you made the diagnosis of broad complex tachycardia, 75% of your problem is sorted. So after that, then you can think about what form for broad complex tachycardia you are looking at. So by looking at this ECG, you see white QRS complex, so the broad complex regular tachycardia. So if you get the diagnosis of broad complex regular tachycardia, you manage as ventricular tachycardia, and I will further discuss what are the other features of ventricular tachycardia. But the most important diagnosis, first you come to the diagnosis broad complex regular tachycardia. In a clinical background of 65-year-old patients coming with chest pain, unless put otherwise, your diagnosis would be ischemic ventricular tachycardia, where the management depends on whether the patient is hemodynamically stable or unstable, and when the patient is restored into sinus rhythm, the pattern in the ECG will determine the further management. So if you're looking at this trace, it's a broad complex regular tachycardia, and when you closely look at, there are features to differentiate what type of broad complex tachycardia that you are dealing with. First thing is the complexes are broad. Then you can see the complexes are, the broad complexes are merging with the narrow complexes. So this is called fusion peak. So the ventricular intrinsic ventricular activity or the ventricular focus is firing up with the broad complex, and in between, due to the AV dissociation, some of the supraventricular beats are conducting into the ventricle. So where you get the merging of the sinus beat with the ventricular tachycardia beat. So if you find a fusion beat, unless proven otherwise, that's broad complex regular tachycardia should be ventricular tachycardia. So addition to that, you can see a capture beat. The capture beat means when the AV dissociation happens, time to time the supraventricular or the normal beats can pass into ventricles, because ventricular focus is not always active, or there are some refractory period where the supraventricular beats can reach through the node into the ventricle. So this is a typical of a capture beat. So capture beat means you are capturing the normal beat coming beyond the coming above from the atrial system. So if you see a broad complex tachycardia, regular tachycardia, or the broad complex regular tachycardia with a fusion beat and a capture beat, unless proven otherwise, it's a ventricular tachycardia. If not, if the patient have broad complex regular tachycardia, managed as ventricular tachycardia. So this clearly shows the capture beat, where you are capturing with the broad complex into a narrow complex, okay, due to AV dissociation. And this shows fusion beat, where you get the fusion of a broad complex into a narrow complexes, then you proceed to the narrow complex with a capture beat. And when you see the concordance, chest lead concordance, if you see the polarity on V1 to V6, either it should be all up or either it should be all down. So those all suggestive of ventricular tachycardia rather than other causes of broad complex regular tachycardia, like supraventricular tachycardia with aberrancy. Yeah, so as a summary, if you get the features of ventricular tachycardia, so you will absence of typical RBB or left bundle branch morphology, but still you can have. There's an extreme axis deviation, we call the northwest axis, with the QRS is positive in AVR, and the complexes are quite broader, so usually it's more than 150 or 160, and you have evidence of AV dissociation. That means sometimes you will see the P and the QRS, or the ventricular activity and atrial activities are dysynchronous mode, and you can see capture beat and you see the fusion beat. Okay, or you can have either positive or negative concordance throughout the chest lead. So if you see all these features in a broad complex regular tachycardia, unless proven otherwise, it should be ventricular tachycardia rather than supraventricular tachycardia with an aberrant pathway. So this patient, a 35-year-old sportsman coming with palpitation. So 35-year-old sportsman, we have just seen that previous debate, coming with palpitation. Seems to be hemodynamically stable. So when you look at this ECG trace, it's quite complex. Okay, it doesn't have any exact features of the ventricular tachycardia that I have discussed earlier, but it has certain features. The complexes are quite broad, but not very broad. Okay, so the complexes are in an like QRS complexes, maybe 120 or 30. But you have right bundle branch morphology in V1. Addition to that, you will see this capture beat. So when you see a capture beat, it can't be a supraventricular with aberrancy at all. Okay. In addition to that, when you closely look at, you can see some P waves which are quite closer to the QRS complexes, but sometimes you will lose the P waves because we are buried in the QRS complexes. So when you closely look at, though it's look like a supraventricular tachycardia with an aberrancy, so you have features suggestive of ventricular tachycardia rather than supraventricular tachycardia with aberrancy. So this is quite a different variety called the idiopathic fascicular VT, where the VT arising from the fascicle. But this is quite this is the most common form of a ventricular tachycardia in a structurally normal heart. The importance of identifying the fascicular VT is the treatment is verapamil. It should be the first line treatment if the patient is hemodynamically stable, but if hemodynamically unstable, you have to manage as a any ventricular tachycardia like DC shock. So in fascicular VT, the complexes are broad but not very broad, and you can have right band branch morphology with the RSR pattern in V1, and you can have capture beat, as well as patient can have dissociated P wave. So those features suggestive of fascicular VT. So again, there's a 25-year-old man coming with collapse. So there's a broad complex running. It's regular. It's a broad complex regular tachycardia. But you can't see any capture beat or fusion beat. But interestingly, when you see the 2-3 AVF, the inferior leads are positive, and you can have the left bundle branch morphology in V1 and V6. So in 25-year-old patients coming with collapse, okay, if it is not a fascicular VT, then you have to think about any underlying structural heart disease. So this is a sort of a ventricular tachycardia coming from right ventricular outflow tract, okay, and usually they can have a structural heart disease. So this is arrhythmogenic right ventricular cardiomyopathy. So anybody with a ventricular tachycardia should have echocardiogram or a cardiac MRI for diagnosis of the origin or the cause for this ventricular tachycardia. Well, so what's the pattern of this trace? So it's quite complex, which is evolving with one rhythm into another rhythm. The initial part has some form of narrow complexes, and they degenerating into broad complexes. When you see the broad complex, the complexes are broader, regular, but though it is regular, you can see the complexes are height is changing, and this is called a very typical, very different type of a ventricular tachycardia called the polymorphic ventricular tachycardia. In monomorphic ventricular tachycardia, all your beats are in the same configuration, but here in polymorphic ventricular tachycardia, you have a different configuration of broad complexes. So when you look at closely, so the broad complexes start with this specific event, and you can see there's a T wave, because if a lot of people, postgraduate people are around, then I'm discussing this is in quite detail. So you can see a T wave there. The T wave following, there's a atrial ectopic has placed. So the R is merging with the T wave. This is called the R on T phenomena, and R on T phenomena readily being degenerate into torsade pointis or the polymorphic ventricular tachycardia. But you can have this R on T phenomena without degenerating into polymorphic ventricular tachycardia. But if the patient is in a ET or a CC or a cardiac monitoring, if you are looking at this abnormal complexes like R on T phenomena, patient is sooner degenerate into this polymorphic ventricular tachycardia. So then and there you should identify those things and look for the causes like hypokalemia, hypomagnesemia, or then and there you can treat with magnesium sulfate. So if the patient is getting a polymorphic ventricular tachycardia, you have to treat with magnesium sulfate, which has quite a good response. But if the patient is hemodynamically unstable, you should shock the patients. But other than that, when you closely look at the sinus trace, you can see some T wave inversion and U waves. So the T inversion and U waves are suggestive of hypokalemia. So this is basically a hypokalemic ECG with an ROT phenomena degenerate into polymorphic ventricular tachycardia. You should not miss. The interesting feature in polymorphic ventricular tachycardia is these polymorphic waves are being rotating around the electric axis, and the treatment would be the magnesium sulfate, and patient should need a cardiac shock. It's a shockable rhythm with the patient in a peri-arrest or a cardiac arrest rhythm. Well, this is also quite a common type of ECG. Young lady coming with palpitations, and when you took the ECGs, the ECGs like that. Okay, so But before coming into specific diagnosis, so this is you have to see whether it is a broad complexes or narrow complexes. So this is narrow complex. So in the narrow complex, you have to see whether it is regular or irregular, because the tachycardic patients coming with narrow complex regular tachycardia. So if the patients have narrow complex regular tachycardia, you have few differential diagnoses. And if the patients have narrow complex irregular tachycardia, you have few differential diagnoses. And if the patients have narrow complex irregular tachycardia, you have set of differential diagnoses. That is how you should approach the patient with a either broad complex or narrow complex tachycardia. First to identify the tachycardia, then the complex bit. Okay, the tachycardia, either broad complex tachycardia or narrow complex tachycardia. In broad complex tachycardia, it can be broad complex regular tachycardia or broad complex irregular tachycardia. As same as the narrow complex tachycardia, also the narrow complex regular tachycardia or narrow complex irregular tachycardia. So in narrow complex, irregular tachycardia, regular tachycardia, you have to see whether the first diagnosis should be the AV-NRT, the atrioventricular nodal re-entry tachycardia, which is the most common form of narrow complex regular tachycardia. So this patient has all the features of AV-NRT, where I'm going to show in a little while. So basically what happens in narrow complex regular tachycardia, you have the sinus rhythm is being conducted into the ventricle through a fast and slow pathway. So it usually goes through the fast pathway and activate the ventricles. But sometimes when the fast pathway is refractory, you can't go the signal through the fast pathway due to the refractory period. And if there's a premature atrial contraction happens when the fast pathway is still refractory, it goes through the slow pathway and it goes up through the fast pathway up. Then it happens over and over again as a vicious cycle. So you will activate the circuit around the node for AV nodal re-entry circuit. So when you develop this AV nodal re-entry circuit, you will end up with this narrow complex regular tachycardia. So as a feature, so they have narrow complex regular and the P waves are retrograde because the atrias are being activated retrogradely from the ventricle. And these P waves are quite difficult to differentiate. Sometimes P waves are buried in the QRS complex. So you will not see the P waves in the and this QRS complex separately. But sometimes you can see these P waves occurs after the QRS complex in V1, where you can have pseudo R wave because these are positive deflection. But in the inferior leads, you can have as a negative deflection as pseudo S wave. So when the re-entry circuit is active, you will get narrow complex regular tachycardia in the absence of P waves, or the P wave will be after the QRS complex. And there are different morphologies where you can find these P waves hidden in chest lead or in the inferior leads. And the other thing is you can find the QRS alternates. The different sizes of QRS complexes can be seen in this patient with AV-NRT. And you can have this QRS alternates in patient with cardiac tamponade as well. But in that case, your total complex height will be smaller. But here you will get the normal complex height with the beat to beat variation in the height. This is called the QRS alternates. So, if the young lady coming with a narrow complex regular tachycardia with retrograde P waves and pseudo R, pseudo S waves with the QRS alternates, unless proven otherwise, that is supraventricular tachycardia or AV-NRT. So, the supraventricular tachycardia is a broader, non-specific term, but everybody is get used to say it's supraventricular tachycardia as AV-NRT. But one of the the component in supraventricular tachycardia would be AV-NRT. Due to re-entry circuit. And so this is 67-year-old patients coming with palpitations. So when you look at the ECG, so always when you see a tachycardia, you have to see whether it is a broad complex tachycardia or narrow complex tachycardia. So by looking at this ECG, it's not a broad complex, it's a narrow complex tachycardia. The narrow complex tachycardia, you have to see narrow complex regular tachycardia or narrow complex irregular tachycardia. So when you look at these patients, it's a narrow complex regular tachycardia because RR intervals are quite same. Then only you have to find any specific features to differentiate the type of narrow complex regular tachycardia. So the striking feature in these patients, you can see the flutter wave. So the sawtooth appearance of flutter wave. So if you see a sawtooth appearance of flutter wave, then you can make the diagnosis of atrial flutter. If you diagnose an atrial flutter, you know the normal flutter wave would be 300 frequency, but you have to see the RR interval. These RR intervals are exactly fitting from two large squares. That means the heart rate is 150. So then, when you diagnose 150 range with an atrial flutter, it should be a atrial flutter with 2 to 1 block. Because atrial flutter with 1 to 1 conduction, the rate should be 300. But if the rate is 150, means atrial flutter is 2 to 1 block. So it's easy to, if you know the algorithm to differentiate, when you see a tachycardia, see whether it's a narrow complex or broad complex. Narrow complex, see the regular narrow complex or irregular narrow complex. In a regular narrow complex, see the specific feature whether it's a sinus tachycardia or an atrial flutter or atrial tachycardia. So those are the three differential diagnoses or AVNRT, the four differential diagnoses that you are interested in. So you can see this flutter wave, okay, sawtooth appearance with a frequency of 300. Depending on the total heart rate, the atrial flutter can be either atrial flutter with 1 to 1 conductions or 2 to 1 conduction or 3 to 1 conduction or a 4 to 1 conduction, or maybe sometimes irregular variable conductions. So this is atrial flutter with 4 to 1 block. Okay, so you can see regular the narrow complex regular tachycardia with heart rate of 70, around 75, and you can see these flutter waves. Yeah. So this is a 75-year-old lady with shortness of breath. It's quite a common ECG and it's a quite a common clinical scenario. The elderly lady coming with shortness of breath, okay, found to have this form of a ECG. So if you find this form of a ECG, this look like tachycardia. You can have a heart rate is 100, 110. So go for the algorithm. So it's a narrow complex tachycardia. It's a tachycardia. It's a narrow complex tachycardia. It's a narrow complex irregular tachycardia. If you further see, it's narrow complex irregular tachycardia. So if the patients have narrow complex irregular tachycardia, unless proven otherwise, that is atrial fibrillations, where you don't see any P waves but in a irregular baseline. So this is a patient with a atrial fibrillation, the ECG that you should not miss because it has many treatment options, like we have to control the rate and patients might need anticoagulation depending on her clinical profile. Well, so this is also quite important, ECG. A 45-year-old patient coming with angina. And when you see the ECG, you can see there are some specific changes in the chest lead. Okay, you will see some biphasic T wave in V1, V2 and V3 and up to V4. But you don't see any ST segment elevation, but the R wave is preserved. So if you see this pattern in a background of chest pain or ischemic heart disease, you have to come to the diagnosis of Wellens syndrome. Wellens syndrome is a pre-infarction syndrome where the left anterior descending artery is in a critical state where sooner the artery is going to be occluded and ST elevations can happen. So identification of this Wellens ECG is important for early referral for the cardiology team. The patients might be advantage of CCU observations and going for early invasive strategy. So the Wellens syndrome is basically, there are two types of Wellens, Wellens type 1 and type 2. The type 2 is more common than type 1, where you get biphasic pattern of T inversion in V1, V2, V3 can extend into V4 and V5. And there are no ST elevations, but the R wave is preserved. So this is the typical Wellens type 1. So whether it is type 1 or 2, it doesn't matter. It suggestive of a critical LAD stenosis where the patients need urgent early invasive strategy. In Wellens type 1, you will not get the biphasic pattern, but it's quite a deep symmetrical T inversions in V1 to V3 or maybe extending to V4, V5. But still the ST segment has not been elevated, the R wave is preserved. If you do high sensitivity troponin, the troponin might be either negative or might be marginally positive. When you do an echocardiogram, usually it's negative. But if you do an angiogram, the patients might have critical LAD stenosis. So if the patient is not timely diagnosed as well as not timely sent for the appropriate referral, patients might end up with full infarction with a transmural uh, anterior ST elevation myocardial infarction. It is very important to identify that Wellens ECG pattern. So this patient is a 65-year-old patient with resting angina. So if the patient have resting angina, you know, the patient has heart attack. It doesn't matter what type of heart attack, but anyway, the patient has some form of heart attack. But quite interesting, if you look at to identify what sort of a heart attack is going on, you can have some form of an idea. When you look at the V2, V3, you have some form of a ST depressions. Maybe upsloping or maybe horizontal. In addition to that, there are tall tented T waves in V1 to V3. So if you see this the specific pattern, but there are no ST elevation anywhere. So if you get these tall tented T waves and ST depressions, maybe upsloping or horizontal, you come for a diagnosis of De Winter's T wave pattern. So that is also one of a pre-infarction syndrome where the patient sooner going to develop an anterior or anterolateral ST segment elevation MI. So if the De Winter T wave pattern is identified at the ETU or at a medical ward, okay, the patient should be immediately referred for a cardiology team where the patient with extensive cardiac monitoring plus the early invasive strategy would be beneficial, because they are sooner going into develop full transmural myocardial infarction where the full blown heart attack going to be happen. So the De Winter's T wave, if I summarize, the tall prominent symmetrical T waves in the precordial lead V1 to V3 may be extending up to V4 and V5. You can have upsloping ST segment depressions, maybe more than 1 millimeter at the J point. And absence of ST elevation, so these patients will not go for primary cath lab because there are no ST elevations, so they may be in the ETU or going for medical ward. ST segment elevations in AVR can be observed, and if you are not properly managed, the patients can develop into ST segment elevation myocardial infarction sooner. And usually this De Winter's T wave pattern happens in the anatomical point of view if the patient had a large OM1 going to be nearly occluded. So this is 69-year-old patients with angina. So by looking at ECG, there are there are some changes, but there are no dominant ST elevations like in the chest lead, but there are some ST depressions. You might think this is a non-stem is happening, but if you closely look at, you can see some ST elevation in the AVR. Okay, so if you have ST elevation in the AVR with widespread ST depression in the elsewhere, suggestive of either critical triple vessel disease or a left main occlusion. So patients can have some form of an angiogram like that, but the ECG may be sometimes subtle. But if you have missed this AVR ST elevation with widespread ST depressions, you might miss the patients. So this patient also need an early referral for cardiology team and extensive monitoring and an early angiogram, early invasive strategy with going for a definitive treatment. Yeah, so this 65-year-old lady coming with disease pain, so no chest pain, disease pain. But when you look at the ECG, you will see some abnormalities. Okay, so you can identify certain traces. Okay, so this is look like a sinus beat light. Okay, but you can see multiple P waves. Okay, so this is a P wave, this is a P wave, this is also a P wave, this is also a P wave, this is also P wave. Sometimes you can see, you can interpret like this is T wave and this is U wave and this is P wave. So when you interpret like that, this is a sinus. But when you look at the P wave, sometimes there will be no P wave here. This P wave is very close to QRS complex. Okay, and this P wave is not very close to the QRS complex. So this is AV dissociations. You have your P waves in their own rate, but if you calculate or if you monitor the length, this is P, this is P, this is P, and this is also a P wave. Okay, sometimes you will not see the P waves in a normal morphology. So your eye should be trained to identify the P waves hidden in the QRS complex. So this is also a P wave and this is also a P wave. Okay, so if your eye is not trained to P wave, you will not catch these abnormalities as P wave. So this is AV dissociation with the atria running in a different rate and a ventricle running in a different rate. It's complete heart block. The complete heart block, not all the time the QRS complex should be wide. So the patients can have the narrow QRS complex if the block happen quite closer to the AV node. So this QRS complex with the complete hardwood, actually you don't need to worry much. They are not going to die most of the time because the QRS complexes are narrowed, as well as the patient has quite a good reasonable heart rate. But if the QRS complexes are broader with the running with extreme bradycardia, then there's impending some form of a cardiac arrest. Yeah. Yeah, this is a 35-year-old male at a medical checkup. So that means asymptomatic patients coming for medical checkup, you're going for abroad and you go universities and all. When you closely look at, you can see there are some P wave which are very close to QRS complex, okay, which is the short PR interval and a upwards, a slurring of S wave. All are suggestive of a WPW syndrome. Okay, so it's a WPW pattern. It is asymptomatic, but they can have various form of arrhythmia producing WPW syndrome. So this is the short PR interval and a upward slurring of S wave, suggestive of this aberrant pathway conduction. So it's a, if the positive deflection in V1 is like look like the A, like the capital A, like okay, this is the positive deflection in V1, it's WPW type A, and if it is negative, we call it WPW type B. Whatever the WPW, the important thing is the PR intervals are shorter, and there will be a delta wave before the in the QRS complex. There's a delta wave. But the same patients had a palpitation and fainted, and we have to cardio the patient. So the same patients had this asymptomatic ECG WPW syndrome can come with this form of tachycardia in the next day. So when you look at the ECG, it's a tachycardia. It's a narrow complex tachycardia. It's a narrow complex regular tachycardia. So narrow complex regular tachycardia can be AVNRD, or it can be sinus tachycardia, or it can be a atrial tachycardia. But when you see, you can't see P wave, so it can't be a sinus tachycardia. Then it should be a like a supraventricular form of a tachycardia. So what actually happened is in the aberrant pathway and the normal pathway, so your impulses generate from the atria can go through the node and the normal pathway into the atria, and sometimes these impulses can go up through the aberrant pathway and make a re-entry circuit, so which is called the orthodromic AVRT, where you can't differentiate from AVNRT. Okay, so because your complexes are going down through the normal pathway and going up through the abnormal pathway, and always the QRS complex is being generated when the impulses are going through the normal pathway into the ventricle. But if the opposite happens, okay, then you will develop a broad complex regular tachycardia, because in this scenario what happens, your impulses from the atria goes through the aberrant pathway down and it conducted upward through the normal pathway. So if the patient comes with a WPW with a narrow complex tachycardia, you don't need to worry much. You can manage as a conventional AVNRT or a supraventricular tachycardia. But if the patient having this broad complex regular tachycardia or a broad complex irregular tachycardia, they have a high likelihood of degenerating into atrial fibrillation. And if the patient have a broad complex atrial fibrillation in WPW, sooner they can degenerate into ventricular fibrillation. So in that scenario, you should do an immediate cardioversion, and the patient should be referred for cardiology team and the EP team, where the this aberrant pathway should be burned out and blocked. Otherwise, they are more prone to get ventricular fibrillations and sudden cardiac death. Well, so this is 55-year-old man from a CCU clinic presented with disease specs. So what do you think? This is mostly for postgraduate people, where when you see an ECG and when you see the ECG looks normal, so then they have to have some differential diagnosis. Okay? So if the ECG looks normal, then you have to think, what is hidden in the ECG. So by looking at the ECG, it looks normal. There are no striking features. There are P waves are normal, no ST elevation, and QRS widths are normal. Okay. So in this scenario, you have to have a few differential diagnoses. If you can't figure out anything, so it should be the long QT. And the QT means the duration between the Q to the end of the T wave, and you can calculate the corrected QT with the heart rate. The formulas are available in the smartphone, and if in a male the QT corrected more than 450, it's abnormal. In females it is 470. The important thing is long QT. If the long QT is been not identified and not corrected properly, they can degenerate into polymorphic ventricular tachycardia and sudden cardiac death. So, patient coming from a CCU clinic, if the patient is on amiodarone, you have to change the amiodarone, and if the patient in high dose diuretics, hypomagnesemia, hypokalemia need to be corrected. Yeah, so this is a 25-year-old male in insurance checkup. So what do you think? The ABR is positive. So that is also quite important to remember. If the ECG looks normal and if you are not seeing the striking features like ST elevation, BT inversions or anything, you have to have few differential diagnosis in your hand, whether it is this or this or that. Okay, so then this is a patient with a positive ABR, unless your leads are reversed, and positive ABR with a negative complex in L1 and poor R wave progression, such as to of dextrocardia. So the heart is in the other side, so that is why the AVR is positive, and you are not developing a proper R wave progression, and the complexes in L1 is all negative. Okay, so then this is dextrocardia. So if the ECG is normal, look for dextrocardia, look for long QT, and there are a few more. Yeah, so this is also quite important. So we get referrals, okay, from a non-medical ward. The ECG of a surgical ward patient who's having a low urinary output. So this is a common scenario, okay, and especially in psychiatric ward patients also coming with this form of ECGs. When you look at this ECG, immediately the patient should have a medical referral. So that is the first thing for the ward, where you will see a broad complex and not typical of left bundle branch, and you can't see any P waves. This pattern is sine wave due to severe hyperkalemia. Okay, so if you see this ECG pattern, do immediately consult your medical team or the cardiology team. The patients need a calcium gluconate first rather than the insulin dextrose. The patient's membrane should be stabilized, and after that, patients need a insulin dextrose followed by definitive treatment to correct hyperkalemia. Yeah, so the patient at the medical clinic, if you take the ECG, you can see some changes. Okay, so sometimes it looks normal, but you can see a small spike there. These are called the pacing spike. Okay, so sometimes patients forget that they are on a pacemaker, but they are coming with this ECG. When you look at the ECGs and when you ask from the patients, the patients can remember this pacemakers is being placed, because the pacemakers have been placed for a couple of years ago, maybe 10, 20. And the same, little different, but sometimes you can see two pacing spike. Okay, but if you see a one pacing spike, most likely it's a ventricular pacing. But if you can see two pacing, it's a dual chamber, both atria and ventricular pacing is happening. Addition to that, you will see it's on not on demand, it's fully active all the time. Yeah, so this is 16-year-old boy investigating for palpitations. So when you look at the ECG, there are some abnormal complexes can be seen in the chest lead, where some ST elevation. So ST elevation in 16-year-old quite less likely of heart attacks. Then you can see a right bundle branch morphology in the V1 to V3. So if anybody with a right bundle branch for morphology with ST elevations in V1 to V3, you have to think of Brugada. But the most important thing is, if the 45-year-old patients coming with same pattern with some chest pain, either couple of hours before or now, then don't diagnose Brugada straight away. So patients can have anterior ST segment elevation with a pre-existing right bundle branch block, because the right bundle branch block is there in the community. So if anybody with ST elevations in a reasonable background of ischemia, always consider coronary artery disease. Once you exclude coronary artery disease, then you can come to the diagnosis of Brugada. So the Brugada has different morphologies, maybe type 1, 2, 3. But the most common and the most easy to differentiate pattern is this pattern with the right bundle branch block with a ST elevation in V1 to V3. Well, so this is the last one. A 65-year-old patient with confusion. So, if the patient is coming with this deep symmetrical T wave invasion in the chest lead, we tend to think about coronary artery disease, and you're doing troponins and ECGs and sending for echoes and all. But always you have to think there are some other non-cardiac causes also causes ECG changes. So this patient has a severe intracranial problem. That is why the confusion happens. Okay, but the patients have a very deep symmetrical T wave inversion. Sometimes this is being called like a cerebral T wave inversions with an increased intracranial pressure due to ICH or infections or the big stroke. You can have this form of ECG changes. So likewise, these ECGs are not only related to heart. Okay, so it can manifest the cardiac problem mostly, but there are some non-cardiac manifestations as well. So in general, I try to cover the reasonable stuff of ECGs you should not miss. But the ECG is quite a vast, extensive area where you have to read with this stimulation. Then you will find different diagnoses and different features. Thank you.